Questions. Now, on your programme, it says that Barney Hawthorne and Sean Weaver are going to be presenting. Barney's had his fair share of presentations and chairing, so I think he was delighted when Sean said to him this morning, do you want me to do it? Sean, thank you for joining us. Sean is, for those of you who don't know him, is from the Royal Bournemouth, but he's also recently been appointed as the clinical lead for the Royal College of Physicians on quality improvement, specifically with IBD. So it's great to have you with us, Sean. I know you've hot-footed it here between ward rounds almost, so over to you.
More of that later. Thank you, David. My name is Sean Weaver. I'm a consultant gastroenterologist. I've been in Bournemouth for 13 years, and I lead the IBD team there. These are my declarations, and the one to point out is I've been funded by the Health Foundation. It was lovely to hear them the support of the first IBD audit. The Health Foundation have funded a program called Generation Q, which puts people, health professionals, not just doctors, through a master's course in quality improvement, and I've just finished that. I'd recommend it, and I'm happy to talk about it afterwards. Always start with thank yous. It's an honour to be on this stage. It's an honour to be thinking about Richard Driscoll. I had lots of emails from him supporting our perseverance and patience with the registry, and it's a pleasure to be in Liverpool. So thank you for the invitation, particularly Barney. So we've spoken a bit about the registry and more of that to come. We've touched on standards, which is how we should do our job, and there'll be guidelines. We've had a fabulous talk from John about research, which is central. And the colleges, and what I've been asked to talk about today is quality improvement. I am not here to give you more standards. I am not here to tell you how to job. Quality improvement is a jargon word for change, and there are some clever ways of doing change better, and that's what the college want to support. We think quality improvement, and I certainly embarked on a master's thinking this will all be about numbers and this will be quite easy because we're all health professionals and we all improve quality. And sometimes you can improve quality at a stroke. When we went from one doctor to 2 doctors on the ward, the quality just got better at a stroke. You didn't need to measure it, it was obvious. But quality improvement is different, and it's about bringing measurable improvement. Keith has gone, but that data, measurable reductions in mortality, which the audit did, which was fabulous, using scientific methods in a healthcare setting. There's a variety of approaches. So I live in Bournemouth, sunny Bournemouth. I have a beach hut, and water displacement 1 wasn't very good. Water displacement 2 was even worse. Water displacement 40, after Norm Larson spent 40 goes at getting ways to keep my beach hut openable in the winter, is there. So this is an iterative process. You go over and over again, and it assumes you will fail. So you've got to be brave. You've got to try things, and sometimes they won't work. And certainly I think I really struggle with that, because you want to get it right first time. And the whole principle of quality improvement is you will not get it right first time. You'll need at least 40 times. And once you've overcome your pride and established a modicum of humility, you're on the road to getting there. A struggle, certainly, for me. Toyota did lean, and you'll have heard of hospitals like Virginia Mason in America have really embraced lean. That's one way of doing it. Their obsession with waste. Think about the waste that goes on in the NHS. We're all very busy, we're all absolutely frantic, but there's still waste, and we know where it is. And you know what? Our patients know as well. And then there's the model for improvement, which is the model the college will be basing their work on, which is like a rapid audit cycle, a rapid cycle of improvement where you have an aim, a goal, you measure something, you try something different, and you do a plan, do, study, act cycle. And this is the IHI model from the Institute of Healthcare Improvement. Very common, used a lot in our universities to train our trainees. It's not the only way of doing it, and I'll be giving some alternatives, but it is a nice, easy model because we kind of get it. So when you do that, you get numbers. This is a simple graph. So you do a change and nothing changes, and then you do a second change and something's different. And so I love numbers. Numbers are really good. They're easy. They convince me. They don't convince most people. We work in healthcare. People like stories. They like how it feels. So careful with numbers as a lover of numbers, because they can be really complicated. And this is some data about length of stay in Bournemouth dropping 18%. The amount of work in that graph is huge. So run charts are lovely, but they will not win everyone over. And the registry will be great at producing charts, which are going to be really important. But one of my messages today is they are not the only way. So I'm going to launch off with a slight tangent, or so I thought, but actually I've heard so much of the patient voice, which I worry does not get heard enough. And thinking again of Richard, I think that's really important. Today is What Matters to You Day. And the only way you can find out what matters to your patients is to ask them. We love measuring things that matter to us. We love measuring things we can measure, but measuring things that matter to our patients, that incontinence, urgency, fatigue is far different. So there's a huge social media thing about this, and if you look for it, it will overtake you. So I'm here between ward rounds. I did a ward round yesterday. A lady got infliximab on my ward yesterday for her colitis. She won't remember that, because on Monday when I said to her, we're waiting for your stool culture, but I think you'll be getting infliximab tomorrow, she said, my daughter's last dress fitting is tomorrow. And so in 10 years' time, she won't remember her infliximab, she'll remember the dress. And that's, unless you cannot work with your patients to provide a high-quality service without asking them. And Bournemouth, we've done a lot of culture, and so patients and staff are too busy to get to meetings, so we go out and talk to them. So this is the NAF trolley, which is, I think it speaks for itself, and it's about what matters to you. So I would encourage you, and it's difficult to measure, but it's not impossible to measure. So I caught a train from Manchester Airport yesterday. I caught it at 4:22. I got into Liverpool at 17:55. The outcome was perfect. The outcome was as expected. The experience was shocking. So we love outcomes, and it's relatively easy to measure outcomes, but we need to be a bit brave, a bit humble, a bit out there, and ask our patients how it feels. And that can sound a bit nebulous, so whenever I put a picture of my family up on the screen, so my wife's taking the picture, on that picture is my mother, my children, my sister, her husband, my niece and nephew. So Keith, on the right, got colitis last year and lost his colon. Not looked after by me, looked after brilliantly by Frimley, and I'm very grateful for Sarah Langlands and all their work. When you see it happening to your family, he was put on cyclosporin, he perforated his duodenum spontaneously on cyclosporin, and that was the outcome. How it felt was my sister phoning me up saying, I think he'll die. He didn't, he's really well. And he said, and John Mansfield reminded me of this, speaking both about the patient voice, a smiley team. If you're enthusiastic about something, it's infectious. If you stand there being glum, everyone's glum. And so that your emotions can take over and help our patients. And when I asked him last night, and I said, it's all with his permission, he said, it really matters. And going the extra mile, his registrar took him down for a scan. I don't think it was because he was related to me, but it might have been. And my sister said, a consistent voice from all the teams. We work in an ever more rotating, multidisciplinary world. It's nice having the same consistent message, and communication really matters. So there's a temptation with quality improvement to get sucked into quantitative data. I've grown up with it. I've got a molecular PhD. I love it. Actually, be careful there. Think about qualitative stuff and ask your patients, and kind of treat them all. I love the fact she's blindfolded. Treat them all equally. So back to how we integrate in with the registry standards, our patient voice, and how we can improve. The college have been supporting quality improvement and quality in IBD for a long time. We've already heard about Richard's work setting this up, the Health Foundation funding it, the wonderful improvements in data that we've got. And there have been some superb work about which we can build on. The college are keen to have quality improvement embedded in how we work, and they've set up a quality improvement hub, and John Dean is the clinical lead for that. And they've chosen some subjects to lead on that, and they've chosen IBD because they've got such a history. And they did a pilot last year. Quick hands up, anyone here in the pilot? There were 8 teams? No. So 8 teams, and they came as teams, and they did work collaboratively with 3 meetings, 3 sessions, to improve their quality, to do quality improvement. And as a result of that, there's an offer which I'm just about to come on to of what the college will be doing this winter. So what did they do? They asked people to come as a team. They gave them some work, and they said, we're not here to give you problems to solve. what problems have you got? Do you think you're good at getting stool cultures? How good are you at reviewing your stopping of biologics? Really well every year with all those numbers? What is your problem, and how can we support you and upskill you with some quality improvement techniques to make that easier? It's all about change, and we don't like change, and it is quite difficult. And you do it 3 times, and they used a plan, do, study, act model, which we're happy to support, but there are other ways. And when they started, at the beginning, how confident are you of participating in a quality improvement project? 91%. They said, we can do this. We're doctors, we're nurses, we can do quality. How good are you at training this? Yeah, we're not bad at that. That went down because they found it more difficult once they got into it. Actually, change is difficult. And learning some of the skills that can help. So I went through a master's feeling as I was losing knowledge because I realized how much I didn't know as I went through the 2 years. So what's the college offer? 3 sessions because it worked. It will be practical. You will bring a problem which you are struggling to change, and we will try and support you to improve it. It will be a whole team. We're not trying to tell you what to do. We're not going to be prescriptive. But the assumption is it will be at least a doctor, a nurse, hopefully a patient, perhaps a surgeon, dietitian, pharmacist. It depends what you regard as your team, and the core of that can be defined, but it kind of gets a bit blurry at the edges, and other hospitals work in different ways. You will set the aim, but you will not get it right first time. And when I was hearing about the pilot, they said everyone came with a problem, and by lunchtime they perceived their problem in a different way. And I tend to come in, I intrinsically want to find solutions, and actually you've got to start with an open mind. So the questions, the funding, it's an offer from the college, and it can't be run for free. The college do not have the money. So it will have a cost. The pilot was free. This is likely to cost £1,000 to £2,000 per team. I struggle with that, and I've had a debate with the college, but they can't run this for free. I personally, in finding money, I lead an IBD team, so I know what it's like finding money, immensely difficult. And I don't want to be competing with the registry, and I think a team that's thinking about quality is intrinsically signed up for the registry, so I think that should be a kind of a given. It will be cheaper the more teams are involved, and collaboration is good, but if you have too many people in a room, it gets quite difficult. So this is what we're thrashing out this summer, and then but over the winter we plan on running these 3 sessions, and it will be visible and advertised to you all. I'm coming to a close. So take-home messages. I think quality improvement is change, and it's an essential part of what we should be doing in IBD. The RCP is keen to promote and support quality improvement, give you the skills, not tell you what to do. And there'll be an offer coming out over this winter. And it should integrate, not compete with, the standards, the registry, the research. And on what matters to you day, it doesn't have to be numbers and graphs. It can be how it feels. I'd like to start with how I finished, and thank you, and I'll take questions at the end when we have our panel. Thanks very much.